Welcome to our third session of implementing the PRED approach to develop pandemic preparedness and response plans for respiratory pathogens. Today, we're going to get started as soon as possible, and people can join us as they can, because we have a full session today and have two very important topics that combine under the collaborative surveillance. So we have Dr. Olivares, who will speak about the considerations for epidemiological surveillance before and during a respiratory pandemic, and Dr. Juliana Leite. So I'm just going to project my many apologies. Getting all sorts of notifications here. And we have Dr. Leite, who's going to speak about laboratory surveillance for preparedness and response to respiratory pathogens with a pandemic potential. So as we said, this session will take place on two different blocks, and then at the end we can have questions and answers, and we'll have just a closing remarks and next step session. So please keep your questions for the end, and but if you have any burning questions, please drop them in the chat. Ornella Cyrus cannot join us today because she is in deployment in St. Lucia, actually supporting the country in an in-person session while they develop their pandemic preparedness plan. So, but any questions, always Ornella is available to support you. So without further ado, I would like to give the floor to Maria Fernanda, who is going to present on the epidemiological component.
Thank you, Evelyn. Hello, good morning. As Evelyn was saying, I'm Maria Fernanda. I work in the influenza surveillance team. Today, I'm here to talk about collaborative surveillance on behalf of the influenza team. In this presentation, we will discuss what collaborative surveillance means, the best strategies to achieve it, and some examples. Next slide, please. Next slide, please. First of all, what do we mean when we talk about collaborative surveillance? It's the systematic strengthening of the different components and their capabilities, both within and outside the health sector. All of this ultimately aims to enhance public health intelligence and improve decision-making through high-quality evidence. Key stakeholders include animal sector, agriculture, and environment, which are particularly relevant in the context of respiratory pathogens. Next slide, please. Epidemiologic and virologic information needs to be gathered throughout a respiratory pandemic because it enables public health authorities and policymakers to make evidence-informed decisions to protect their communities. Surveillance of influenza and other acute respiratory viruses during the interpandemic period provides critical information to support public health responses and decision-making. Countries have multiple objectives that they seek to fill with annual surveillance for influenza and other acute respiratory viruses. Here within the PRED framework and the pandemic cycles that we are seeing in this figure, we are currently in an ideal period to develop plans and prepare for the next introduction or reemergence of a new respiratory pathogen. This is why keeping our system alert and ready as well as identifying gaps and opportunities for improvements, is the main goal of this workshop. Next slide, please. Why is it important to keep surveillance systems prepared? First of all, to provide data to guide responses to health threats and resource allocation. No single system can address all aspects of respiratory virus surveillance. A multi-system approach is essential for informing policy and interventions at the national level. Surveillance systems must be tailored to the specific public health needs for each country. The main objectives are these three that are mentioned now. First of all, detecting emerging viruses and rapidly assessing transmissibility and clinical severity. This is the first one. The second one is monitoring epidemiological, clinical, and virological characteristics of circulating respiratory viruses. And last, informing the use of these interventions to mitigate the impact of emerging and seasonal viruses. These systems work together like tiles in a mosaic, forming a complete picture of respiratory viruses and their impact. Next slide, please. What are some of the considerations that impact collaborative surveillance for pandemic preparedness? The first one will be identifying and address gaps in surveillance systems. And PPRP should recognize that a response for the new pathogen will rely on multiple sources of information, local to global systems, and capacities of collaboratory surveillance, laboratory services, and risk assessments rely on multiple sources of information, including multi-sector data that provide contextual insights. One good example of methodologies are the Mosaic framework and sentinel size evaluations. The second one is establish and maintain multi-sectoral technical operational groups. Operational is a very key component of this at this point. The One Health approach, human health, animal agriculture, and environmental should be integrated to facilitate prevention, preparedness, detection, and response efforts for emerging respiratory pathogens. Joint risk assessment and response to outbreaks are good examples of a multi-sectorial approach. Another consideration to have in mind in preparation are the increased demand for laboratory and surveillance systems that can occur during a pandemic. The information systems play a crucial role in rapidly providing key information and supporting the development of effective countermeasures for new respiratory threats. The next slide, please. The surveillance approach used during interpandemic periods can and should be the surveillance approaches that are used during a pandemic, with modification as appropriate. First one, detecting emerging viruses and rapidly assessing transmissibility and clinical severity. This is the next slide, please, and it's the first point that we are going to see. It is recommended that in your NPPRP, you describe, and all countries should be prepared to rapidly detect cases in their country or cases of any new pathogen in the country. Approaches to detecting new cases should include health facility-based or community event-based surveillance, nationally notifiable diseases and condition systems, existing laboratory networks, and possibly targeted surveillance in special populations. For example, returning travelers healthcare workers, individuals exposed to animals that could be infected. The second one is assess transmissibility. When a human is infected with a non-seasonal influenza virus, it is critical early in the pandemic to monitor their close contacts for symptoms, signs of possible infection, and have a low threshold for deciding to test close contacts. This contact tracing and monitoring is critical for detecting human-to-human transmission. If human-to-human transmission occurs, transmission investigation should occur to gather more information about the modes of transmission, risk factors for transmission, duration of infectiousness, and transmission dynamics. For example, secondary attack rate, serum interval, and incubation periods. Last one, describe clinical presentation and risk factors. Investigations of initial case are critical and should be aimed to describing the clinical presentation, clinical severity, including whether a case was hospitalized, was admitted to an intensive care unit, or died. And the risk factors for infection and severe outcomes. These 3 points are very important in the interpandemic period and routine surveillance, for example, to detect something that could occur and could mean something more, something big, for example, the next pandemic. The best surveillance approach to rapidly detect those unusual events is the event-based surveillance. And here are some examples of signs that we need to be aware and the best surveillance strategies to detect these signs. These signs are related, for example, to a potential exposure to a virus. The first one, respiratory illness, conjunctivitis, or encephalitis in humans with recent exposure to animals, contaminated environments, or suspected or confirmed human case of an emerging or re-emerging virus. SARI, the presentation of SARI or pneumonia in travelers, in healthcare workers, or laboratory workers are of special interest to be aware as a sign of something more, of an unusual event. And clusters of SARI or pneumonia in families, workplaces, or social networks, cases with atypical respiratory symptoms. And the best surveillance approach are EBS in healthcare facilities, EBS in the community, monitoring of media and rumors, and also the notification from animal surveillance sources. For example, for high pathogenic avian influenza. The next slide, please. We can have example of signals for early detection. Here we have 2 surveillance strategies. First one, the surveillance in health facilities, enhanced surveillance for people, healthcare workers or laboratory workers that could be exposed to patients who had been exposed to some to avian influenza viruses, and a special targeted surveillance population. For example, in people at risk of exposure. Here it's important to have implement standardized guidelines to have the step-by-step for the detection, register of the case, and notification to the authorities of these cases, of these suspected cases and confirmed cases of avian influenza, for example. Next slide, please. The second approach for collaboratory surveillance is monitor epidemiological characteristics of respiratory viruses in interpandemic and pandemic periods. And here is especially focused on IBS systems that can be in place on your country and may include notification diseases surveillance, targeted special population surveillance, as we've seen in the example before, laboratory networks, Sentinel, ILI, SARI surveillance, and healthcare capacity monitoring. Countries should prioritize the use of an existing Sentinel surveillance approach for ILI, SARI surveillance, including adapting an integrated disease surveillance approach before pursuing a new system for use during a pandemic. This is especially important as we had seen in the COVID pandemic. The Sentinel SARI system was in a very good place to catch those first cases and rapidly integrated to the surveillance system and to monitor the trends after. In the NPPRP, you can describe how these systems are set up to monitor epidemiological and clinical characteristics of illness over time, virological and genetic characteristics of circulating viruses, not only influenza, but for example, COVID-19 and RSV, for example, the situation in high-risk settings and vulnerable populations, the impact on and coping abilities of healthcare systems. Next slide, please. The signs, signals for indicator-based surveillance are any indicator that show us a change in the trends. For example, number of respiratory disease hospitalizations or deaths greater than expected of the baseline, increases in mortality in the population in a particular area over a short period, abrupt and unexplained changes in the trends of respiratory disease occurrence or clinical outcomes observed in routine surveillance activities. Laboratory detection of human infection with a non-seasonal influenza virus, a novel respiratory pathogen, or MERS-CoV, for example. The best surveillance approach, as we were discussing, is ILI, SARI, Sentinel surveillance, targeted special population surveillance, healthcare capacity monitoring to see how many beds we have, the proportion of occupied beds in our in hospitals, for example, and of course the laboratory network is essential especially for indicator-based surveillance. Next slide, please. And an example for this one is, for example, the CARPA network urges to strengthen surveillance amid rising in respiratory illnesses. As we were checking in this news, this alert was raised because of the rising in SARI cases, ILI cases in the Sentinel sites. This is important, and it puts in front the importance of the systematic catch-up of the cases. You have quality data to make a community risk communication to the community for improve the catchment of the cases in the area. Next one, please. And this slide is just to give the importance to have this systematic flow of the process that is catch the the case, the sample collection is very important in the surveillance, SARI, ILI, Sentinel surveillance, capture the information of demographics, comorbidities, vaccination status, the follow-up, and the episode if this disease, discharge, all this process on the surveillance system, all these points, checkpoints in the surveillance system, SARI, ILI system, it's very important to have the complete information and to make a best decision in the seasonal periods of the respiratory viruses. Next one. And last one, informing the use of human health intervention to mitigate the impact of emerging and seasonal viruses. As we were seeing, first, we need to rapidly detect. We need to, and the second one, we need to have our Sentinel and indicator-based systems up to date to catch everything in the regular and peace times, but also with all this information, we need to use it to mitigate the impact, not just for the next pandemic, but also in the regular seasonal viruses. The surveillance approaches that can be in place may include investigations and studies and pharmacovigilance. And a good example are the Unity studies. It's a very good strategy. And PPRP can describe how countries will be able to monitor the impact of public health social measures and risk communication and community engagement campaigns, provide candidate vaccine viruses for vaccine composition, production, and risk assessment, and also monitor year by year vaccine coverage, effectiveness, impact, and cost effectiveness of antivirals and other therapeutics, for example, use of oseltamivir, effectiveness of diagnostic tests, of clinical care pathways, including infection prevention and control, and adverse events to vaccines and therapeutics. Next one, please. Here are some examples of interventions and evaluation. For example, the interventions are vaccination, treatments, non-pharmaceutical interventions, and we can measure this through burden of disease, effectiveness, impact, cost effectiveness, through surveillance, and another ad hoc studies data. These results can make policy adjustments and targeted actions in the specific country who is conducting these studies. Next one. To summarize, takeaway messages are being prepared is key. Capacities and partnerships are built in times of peace. This is the best time to strengthen the surveillance, the routine surveillance, the laboratory networks, the governance between agriculture sectors, environmental sectors, and health sectors. The early detection capacity relies on EBS for first detection or re-emerging for a new virus or an unusual event, but also relies on the routine and indicator-based surveillance. Importance on assessing whether human-to-human transmission has occurred, detect further cases, and monitoring community transmission and understand transmission and clinical severity is very important to inform the authorities and keep the community informed of the course of the pandemic, of the seasonal epidemics. Inform the use of interventions such as antiviral vaccines and public health and social measures, it's important to, as we were saying a few minutes ago, to make adjustments in specific adjustments in country policy. For example, expand risk groups in vaccination, for example, or make another risk population subject of interest in any particular surveillance. For example, adults over 65 in RSV, for example, surveillance. Not only just the under 2 babies for RSV, who we know are the most affected, but also the elder community. And this is the last one, I think. Any?
Yes, thank you so much, Fernanda. So if anybody has questions, just send them on the chat, and we will move forward to the next presentation with Juliana. But before we do that, we wanted to take a photo of those who are participating with us today. So for those who wish, you can open your cameras. And Natalia, I think you can take the photos now. Thank you so much.
Hi, good morning. Yes, please put your best face, smile, and okay, everyone, smile. That's it. Yes, thank you all.
Thank you so much, Fernanda, for highlighting all the considerations that we can have for the epidemiological surveillance and the three main domains or components in which we can think of our capacity, of the capacity that are installed in the country, but for the subregion also at the subregion level, because many of these studies require larger sample sizes that might only be able to reach when we pull data from different countries. And so we will send the slides always, but if you have a question, just let us know in the chat. And now, Juliana, over to you for the considerations for the laboratory services.
Thank you, Evelyn. Good morning, everyone. I see some that I already know. The ones that don't know me, I'm Juliana Leite. I'm laboratory specialist from the laboratory response team, and we work together with the respiratory virus here at the health emergency department. Thank you, Evelyn, for inviting to share a little bit about the laboratory surveillance. And also let me share here my screen. I have 3 screens, so let me see if I'm sharing the correct one. Could you please confirm if you see my screen?
Yes.
Okay, super. Thank you. So I'm going to close my video to make it easier. So thank you again for inviting us to talk a little bit about the laboratory surveillance on the preparedness and response to respiratory pathogens with pandemic potential, because that we know, we all know the laboratory the laboratory is the basis, is the foundation of all surveillance, because if we don't know which agent or which pathogen is causing, independent if it is respiratory or any other case, suspected case, if we don't have a good laboratory, we won't know which is this agent, this pathogen. So the laboratory, it has this transversal role in the surveillance system, and it's the basis for all this early detection and for providing information for epidemiology, clinical management, and of course the human-animal interface in the One Health approach. So this would be the structure. Just to share a little bit here in our unit, we have different areas and we all work together. It's important when we're talking about surveillance that all components, they need to work together. It's impossible to do surveillance by yourself without that interdisciplinarity. So why the laboratory response is so necessary? Because beyond the surveillance of endemic pathogens, we need to identify this agent, and this is part of the international health regulation, indeed in the chapter 8, and it's also part of the SPAR, that is a tool to assess the country capacity to respond to emergencies. So it is required that all WHO member states should be prepared to detect and to characterize timely any new agent that enters in the country. So as part of this, as I was saying, sharing the laboratory component is also assessed through the SPAR tool for evaluating the response. So here, just to share a little bit more details, inside the laboratory component, there is several subcomponents, let's say like that. There's all the requirements that are important to sustain a good quality of results, a good quality of testing, a good quality of data that would be generated by this laboratory. And it goes through different areas and activities inside the laboratory, specimen shipping, biosafety and biosecurity, because it's not a matter to protect against protect ourselves from the agent, but also to take care of the agent. I just want to emphasize this because biosafety and biosecurity is something that sometimes it generates a little bit of confusion. Biosecurity is a word that started be talking about, and we hear more nowadays. But biosecurity is like my role to protect the sample, so no one can get the sample from my laboratory and generate any treat or bioterrorism. So we're also working with biosecurity. So it's public health safety as a whole. And of course, laboratory quality, the proficiency for testing in the networks that we work together for all the things. This, I'm going to go very quickly through this, but I also always love to share this slide because I think when we work with an agent, we need to understand what is this agent, where did it come from, where it goes. And then here, the word influenza comes from the Latin word influenza. That means that in the 5th century, people used to believe that the stars were influencing the epidemics and the pandemic. So that's why the word came. But nowadays, we don't have only astrologers. We have microbiologists, medical professionals, and epidemiologists as well. So to work together to respond to any potential epidemic or pandemic. Just a little bit more. Of course, all of us know about the Spanish flu. I'm not going to enter so much detail because of the time, but it was the big pandemic that decimated more than half of the world population. If we go back to history, 1918, when we were having the first World War, so the conditions were very appropriating for the virus to be disseminated. And when we look to this, when we have mass gathering, even if it's the soldiers or the war people, and we have poverty, and we have a lot of consequences of the war, we will see it with a perfect scenario for the virus disseminating. And I love this picture, especially here, because even the cat was using a mask to protect and stop the dissemination. So this is what we saw also with the COVID. In that period for Spanish flu and for the COVID-19 pandemic, we didn't have antiviral, we didn't have vaccine, so we needed to isolate to try to control the pandemic. And of course, influenza, we are always being prepared for when it's going to be the next pandemic. We had the Spanish flu in 1918, the Asian, Hong Kong, and the swine flu in 2009. So we are always be working, preparing ourselves to respond to a next influenza pandemic. And of course, because this virus is a virus that has a segmented genome, it's more likely to have regroupment, reassortment, and we can generate new virus can be generated as the last one for the pandemic, 2009, that is different from the one that's a Spanish pandemic because it was a triple reassortment among avian, human, and swine genomes. On the other hand, beside this, we have the mutations that leads to different changes in the viruses that enter in the route intervalent for the vaccine competition. But we're going to focus on the unusual event response and the response for respiratory viruses. So from the laboratory side, oh, I'm sorry that this one is in Spanish. I'm sorry. We're gonna share the slide and then I'm gonna correct. For the virological surveillance, several steps are important and all of these need to be straightening and working very well inside the virological surveillance system as the sample collection, the flow of the sample to the reference laboratory or the National Influenza Center, the laboratory capacity that is not only equipment but also protocols, algorithms, guidelines, the proficiency testing to ensure that this laboratory has the capacity to test well and respond well to this pathogen, genomic surveillance, data sharing that for respiratory viruses, the FluNet reporting, and of course, one of the most important is the notification through IHR official channels. And this is something that is really important indeed when we work with the countries also for the pandemic preparedness plans, response plans. The plans, it's important also to the role of the laboratory on this because sometimes the laboratory, they don't know that they need to notify if they detect something unusual, if they detect something new. So all this communication is important to have. And of course, the referral of the sample to a collaborator center, depending on which virus it is. So talking specifically about the laboratory, the strategy is to straighten the full laboratory platform. Of course, when we're talking today about respiratory viruses, but when we're working inside the laboratory, when you straighten one component inside the laboratory, you're straightening the laboratory in the country laboratory capacity response as a whole. This is a measure that is really important because we can't work like focusing only one pathogen, but it's straightening the full platform as a whole. And as I was mentioning, it's important to have in place national laboratory policies and plans, quality management system, biosafety and biosecurity, testing capacity, network, and of course, evaluation and testing of this laboratory's capacity. So when we talk specifically about influenza surveillance, and of course, it goes also to other respiratory viruses, because of this capacity of dissemination of the virus, it's important to have an on time as for all pathogens, of course, but it's important to have this timely surveillance because it has constant evolution, and it's important also to guarantee that the results are reliable. And the only way to determine, as I was saying, the specific etiology of an IOLI or a SARI case is through a laboratory diagnostics. And because of this, At WHO, we have the Global Influenza Surveillance and Response System. It's like the laboratory component inside the Global Influenza Program. And I wanted to put this slide to emphasize for the Caribbean region, especially for the Caribbean region, this network, it was used for COVID-19 laboratory response, and now it has been extended for influenza and for other respiratory viruses. And of course, through this network, we monitor virus evolution, provide recommendations on laboratory diagnostics, vaccine composition, monitor antivirus susceptibility, generate data for risk assessment, and it would serve like a global alert mechanism for the emergence of influenza viruses or any other respiratory virus that had epidemic potential. Very briefly, we have 151 national influenza centers, 7 collaborator centers, and 4 ERL. These laboratories are the ones that work with the vaccine candidates. They hold the samples for the vaccine production, and of course the age 5 reference laboratories, because we can't process animal samples in the same laboratory that we process human influenza samples, exactly to avoid it's a biosafety measure, so to avoid any cross-contamination or a risk of reassortment among these viruses. And of course, all National Influenza Center, Collaborator Center, and these special groups laboratory, they all work under the WHO terms of reference. This is the web page that we, if I put it here, because in case beside the preparation, if you have any, if you want to have more details in the National Influenza Center. It's inside the Global Influenza Program. We do have Haiti, Jamaica, Suriname, and now Guyana and Barbados as well as National Influenza Center. So this is something that we're working closely with the Caribbean region to give the opportunity to each country to strengthen their laboratory capacity and become in the future a National Influenza Center. This is just the list. We have 32 NICs in 28 countries here in our region. And beside this, just to straighten that the National Influenza Center is designated from the by the Ministry of Health of the country, and is the backbone of the surveillance for respiratory viruses. So just before we enter more details in the laboratory, I wanted to share this picture. This picture is fantastic. Is the first publication of about the Spanish flu. If you see how this show how important it is to generate data and share data. So we see here the epi curve or the virus circulation curve for that period. So it took mainly 2 years to disseminate globally what is not what we see nowadays. The last pandemic in 3 months, it was already cleared. Of course, now we have airplane flights. We have everything that facilitates this dissemination. So we need to respond. And the FluNet is the first, is the laboratory component for sharing these data. This picture here shows how it was formerly. So in 1950, for example, it was radio telegraph communications, and then it came telex, and now we have internet. So how important it is to share, and it's not something new that popped up with the COVID-19, for example. It is important, and it always have been done this monitoring of respiratory viruses data. So going back to the strategy, entering more details in the laboratory, quality management, biorisks, biosafety, biosecurity. This is the basis inside the laboratory. At PAHO, we have WHO as well. We have different collaborative centers. For quality, laboratory quality, we have one in Mexico and one in US. Biosecurity, we also have Mexico, US, and Canada. Indeed, we have, for example, 3 weeks ago, we were with Mexico Collaborative Center for Quality Management and Biosafety in Bolivia for a mission. So just to share that as well, how important is to ensure that everything is working well inside the laboratory. We do also have training courses for online, so it's available also for specific pathogens, and it's available for all the countries. I share this because it's a resource that can be very useful for you in your country, and of course also the biosafety measures that are needed to be addressed inside the laboratories. So it's always important to keep this in mind. We also have manuals for laboratory equipment, for maintenance, and we have been working, providing support for the IATA training, because of course you can't only ship a sample, you need to be trained on how to proper packaging, how to fill these documents, and of course ensure that this sample is going to be protected from the moment it departs from the laboratory until arrives to the reference laboratories. So we have been working, and probably this year we will have infection substance shipping training for the Caribbean region as well. Though laboratory quality is not only when we process the sample, it's all the steps, pre-analytical, analytical, and post-analytical. Pre-analytical steps, it's very important. Proper sample collection, the storage of the sample, and the transport. Why did we write it here? Because if you don't have a proper sample collection, you can try all molecular diagnostic testings and you won't get a result. The virus, respiratory virus, the virus is inside the cell. So you have to do the collect it properly to scrap when you use the swab for nasopharyngeal collection, for example, the storage of this sample, and it goes together with the transport. We can't break the cold chain. And this is really important nowadays that we have genomic surveillance, because the CT value is it's one of the results we have at the laboratory is too high. You can't sequence or you can't subtype this virus. So these are measures that are important and need to be kept in mind when defining the flow and defining the laboratory parts inside the plants inside the country. And of course, all steps are likely to have errors because we're here. Oh, sorry, errors because we are humans, and that's why we always need to have this quality laboratory and good practice training and refreshing activities. One thing that is really important, I put it here, the QR code in case you want to access. I saw that Lionel was putting also in the chat. Lionel, thank you so much. I saw you put some information. So here we have also the QR code. Testing algorithms are important. This is for routine surveillance. So we have it, and it's a reference for the countries, for the laboratories to generate their own. So for the laboratories that send samples directly to the NIC, for the laboratories that test for the first detection, the laboratories and then we talk about sentinel sites or state departments that test and send it already detected or to the National Influenza Center, and of course National Influenza Center that test all the samples. And it's important to have this guidance, which are the differential diagnostic that we're going to do and when we're going to do this difference diagnostic. Do my laboratory, my country have, for example, capacity for sequencing or not? If not, where I'm going to send this sample? So all of these are important, and we added also this one. The QR code is for the zoonotic influenza samples. And when we talk about unusual cases, this sample is precious. I can take the risk to run out of the sample, to contaminate the sample, or break the cold chain and lose the quality, the viral load in this sample. So every time we have an unusual case, this sample needs to be directed immediately to the National Influenza Center or the National Reference Laboratory, because there they will be prepared to process this sample and generate the response and also to ship to other collaborator center or other reference laboratory that needs to be shipped, or CDC or London or CAFA, to whatever they will need to ship, but this has to go to the National Reference Laboratory. And of course, when I'm going to collect this sample, we need to have a high viral load to have a positive result. You should be able to sequence. So it's really important to be strict and try to collect these samples when we have this higher viral load. And for respiratory viruses, the ideal is like 3 to 4 days of the symptoms onset. And here to share a little bit more about networking, I think we are in a period that we can't work by ourselves anymore. And not only laboratory, but also connected epi, lab, clinical information, healthcare facilities, and laboratories, of course. So one example is Pahogen, that is our network is the Pathogenomic Surveillance Network. We had different networks surveilling different agents, respiratory viruses, arbovirus, Helabra, that is for surveilling antimicrobial resistance, and Pulse that is of foodborne disease that now is being sent for bacteria. But of course, we all that work in laboratory, we know that we have the same sequencing platform, so it doesn't make sense to work with each one separated. Of course, this is also human resource, it's financial resource, so everything like this has to be kept in mind. So working as a network, we maximize all these resources that are needed inside the laboratory. Here, very briefly, it's going to be shared the slide. When we created with Vijay, that is the one for respiratory viruses, it was at that moment COVID-19, and it came because of the necessity we saw that there was a bias, mainly most of the sequence was being generated from US and from Europe. And even though in Europe, it was UK and Netherlands that had big consortium. So we started working with our region to straighten this network, and I really like to share Bahamas experience. Bahamas at that moment didn't have in-country sequencing capacity, but every month they were shipping samples. So genomic surveillance not also have to do with the in-country capacity to sequence, but the surveillance at itself. And it's something that is important to straighten is that genomic surveillance is part of the surveillance as a whole. It's not a different surveillance. Like we have virological surveillance, epidemiological surveillance, genomic surveillance, part of all of this to make the whole surveillance inside the country or the region. This was the launch of his vision, because then we incorporated other respiratory viruses, and we're working now with RSV and influenza to straighten sequencing capacity in the country. And all of this goes in line with the genomic surveillance strategy that was approved in 2022 to build and sustain this national capacities for genomic surveillance. Because through the genomic surveillance, we will be able to characterize which viruses are circulating in our country or region, which if this virus is an unusual virus, it's a virus with a pandemic potential. We could identify SARS-CoV-2 variants, detect influenza variants as H1 variants and H3. We generate information for vaccine composition, information for vaccine effectiveness, information for developing updated molecular diagnostics protocol. In 2018, the H3 marker for influenza was updated by CDC. It was again at the end of the last year. So the virus is a virus that circulates with a high tax. So we have the changes for that you indeed results in the different vaccine compositions. Imagine for the molecular diagnostic. So these data also use it for ensure that the the diagnostic protocols are function well, and if it needs to be updated, the sequences or the probes or the primers, and of course, it also the genomic surveillance data provides information for antiviral development and also monitoring of the antiviral resistance, because what makes us able to contain a pandemic? Antiviral and vaccine. So we need to characterize the virus. We need to know what's being detected and we need to know what's circulating. So this is just one more information that's going to be shared, but all genomic surveillance data, it uses it in all steps and generates information for public health decisions. So it's important sample collection, sequencing, but also the linkage with the clinical and metadata, the epidemiological data. So it's important the laboratory to have access to information, because generation the sequence is only the sequence, and then we can't extract any reliable information, important information for a public health response. So from the laboratory surveillance and response, PAHO has been working strategically, strengthening in-country capacity, and inside of this building network, as I was sharing nowadays, it's more than ever important to work together. So it's National Public Health Laboratories, National Laboratories Network, regional reference laboratories, as we have, for example, for Retvigem, Parrugem, and of course, the PAHO collaborator centers. Building capacity and strengthening the laboratories network has been our priority for preparedness and response, and it is important for leveraging the existing network to expand the capacity to detect pathogens, and also to integrate the other components of surveillance. And of course, laboratory networks, they must be fully articulated with the global efforts and regional efforts to respond effectively to an outbreak. And this is the context of PRET, all these series of seminaries that have been provided from the team. And of course, this is in order to improve the epidemic and pandemic surveillance and in response to outbreaks, ensure access to diagnostics and availability to all countries and territory, integrate biosafety quality assurance policies. I'm going to go very quickly because we're getting out of time. I think that's almost at 11. This is just a timeline of hallmark event in our region. So the first NIC designation was in 1951. And we had for example, the IHR publication in 2005. Not sure if everyone knows, but it came after as a result of the SARS-CoV emergency in 2003. How it's important that then these emergencies leads to response and mechanism. In 2014, we have the creation of SARINET that was leveraged to SARINET Plus in 2022, exactly to incorporate the other respiratory viruses. Here, just to share, in 2010, for example, we only had one country shipping 2 samples to a collaborator center. So I'm going to go through this. When we go to the final timeline, we will see that, for example, in 2024, we had 44 countries shipping more than 3,000 samples to a collaborator center. And this includes as well Caribbean region that have been working hard to implement, and this is also a big thank you to you all for all effort to collaborate to the regional and global surveillance for influenza and the respiratory viruses. And of course, a next pandemic will come. We don't know when. We don't know what agent will be, very likely to be a respiratory viruses, but we don't know. So we need to be prepared. This is what it all is about, to be prepared, build capacity, and respond whenever the agent comes. And even for COVID-19, when we had when it came to our region, all national influenza centers, several countries in the Caribbean region was already prepared to respond and detect SARS-CoV-2 before the pandemic was declared. And that's what it's all about, surveillance, to be prepared, respond, and detect. This is just to share a little bit of our capacity here in the region. So we're working to straighten so all countries have at least for the triad SARS-CoV-2, influenza, and RSV. I know there's a lot of how could I say, will to work with other respiratory viruses, but at this moment we're focusing on this triad that will generate more impact on public health and of course to have genomic surveillance for these viruses as well. Resources are important, so we have a lot of infographics for samples taking collection. This one here that is appearing is for respiratory viruses, routine respiratory virus. We have one for zoonotic as well. And these all are available to the countries. You can contact us and we can share this with you if you want to use as material for your country, include the Ministry of Health logo, whatever is needed, we're here to support. And of course, I'm finishing to build capacity and strengthen laboratory network. That has been our priority, and to ensure availability of critical materials. We have in Panama a warehouse, a space in the United Nations warehouse. We have stocks that we have, stockpiles that we have in these strategic stocks we have been sharing to guarantee the implementation of the protocols inside the country. And of course, it's not only about procuring this material, but it's a complete implementation strategy that includes training, quality assurance program, biosafety and biosecurity, and laboratory management. So this is what I wanted to share from the laboratory. I could spend a whole day talking about laboratory. There's a lot to be explored in the different components. But overall, what I really wanted to do is to thank all, I don't know, I'm trying to open my video. I don't know why. Oh, I don't. I want to thank all countries and territory because all of this couldn't be done without you. I think the countries and the territories, PAHU is for you. We are here to support you and to give you mechanisms and resources, and none of this, no global surveillance independent of which pathogen it is, would be possible without all this commitment of the countries and the territories. So this is what I had to share about laboratory, and of course I'm open, I think, together with Fernando, for any question you might have, and also please feel free to contact after the webinar as well. Thank you. Evelyn, I turn back to you.
Thank you, Juliana, for that very comprehensive presentation on very specific items, but important to consider when you're developing your pandemic preparedness plan on the laboratory side. We are over time, but if someone has a quick question that they want to ask, the point of this session is also to ensure that you know who the person is in our office that you can ask questions about each of the topics. So Juliana and Fernanda are, as Juliana said, always available. And don't want to keep you more time. So if you have questions, just let us know. Just to close up, I wanted to say, as we've mentioned in other seminars, based on our review of previous plans, for pathogen-specific pandemic preparedness plans that are already developed in the region, I'm just going to share my screen here. The collaboratory surveillance is the component with the most comprehensive descriptions that we have. So there's a really good baseline for updating your national plans. You can use what you've considered before, and this new information that Juliana and Fernanda have given you with the most up-to-date guidelines, and work on that update. So if nobody has questions, I'm just gonna close the session. Don't be shy. Send us an email. And as always, Ornella is your focal point for any questions you may have, and she will redirect you to Juliana, Fernanda, or you can write to us directly. Thank you so much, and we'll see you on the fourth session when we'll discuss the risk communication and community engagement component. I will be joined by Tanya Escamilla. We will send the slides for all the previous sessions and these ones with the recording to your emails, and we will send the agenda for our next session on the 20th of May. Thank you so much. Bye-bye.